So I don't have to cover too much about this, but I do think it's clear that there is a role for a lot of these different things that you've heard about already. There's a massive evolution that's going on with regards to the reverse. We published on this looking at total shoulders compared to hip and knee. You can see total shoulders have been outpacing hip and knee, although might not catch. It's at least in the last decade and predicted in the future to continue to exponentially increase, partly and mostly because of the reverse shoulder replacement. Unfortunately, as you've also heard, there are certain limitations, and we're still learning about how to overcome this, as you heard in the last sessions. When you look at a normal shoulder and normal scapulohumeral rhythm, and you compare that to that of the average reverse, although reverses can get very good outcomes, and you can get very good motion with them, there is more scapular compensation, almost without doubt. And if you look close enough, you'll see your patients are using their scapula a lot more. It's not normal anatomic motion in a large percentage of these patients. And there's limitations in activities that they get back to, whether it's different sports, different goals that they did previous to the actual replacements, even some ADLs. And so we aren't perfect yet, and I think we're still understanding how to get there. But this interoperative assistance and in some respects, the learning curve, this technology can be useful in this respect. So mixed reality, you've heard about augmented reality, you've heard about guides, you've heard about a lot of ways to do this procedure more accurate. I'm going to talk to you about, at least in my mind, the two big roles for mixed reality currently and going forward in the future. So there's many different guidance. You've heard about many of these. So PSI, there's lots of good data on this suggesting that you can get between 1 to 2 degree error in your plan and your pins placement.